Okay, well, as people are joining, we'll go ahead and start with some introductions. Welcome to the ROVER session for lung cancers. Yet again, we have a fantastic panel this afternoon. I'm pleased to introduce Drs. Dawn Owen from the Mayo Clinic, Dr. Katie Keene, who is joining us from Harvard, and Dr. Percy Lee from MD Anderson. I'd like to take a few minutes to allow each of them to introduce themselves and give us a little background in why they picked radiation oncology as their specialty and what excites them about their jobs on a day-to-day basis. Dawn, would you like to get started? Or sorry, Dr. Owen?
Sure. My name is Dawn. I'm a radiation oncologist at Mayo Clinic, and I have a kind of sad way of getting into it was that my father actually died of lung cancer, and that's my first exposure to radiation oncology. But the amazing thing was that was the modality that helped him the most. So he had metastatic lung cancer. He had a spot that went to his brain, a spot that went to his arm, and he had at least 3 tumors in his lung. And so he had brain radiation, he had spot welding radiation to his arm that relieved his pain. And he was treated in Canadian. And so I did everything in Canada except my medical practice here in the US. And so he was treated at a hospital called Princess Margaret Hospital in Toronto. And the radiation oncologist there gave him 3 rounds of radiation. And each time he was able to breathe better and he was able to function better. Interestingly, he never had any trouble with the radiation that sometimes it causes a burn of the swallowing tube, because he would always eat like a big bowl of pasta right after he had his radiation, and he felt much better. And so I was really enthralled with how much you can help people. And that's one of my favorite things about the specialty. And I'm actually on call right now. And I see patients in the hospital and they're in pain or they have an issue. And I tell them, you know, I can probably spot weld that. I can help you feel better. And it's faster than chemo, and we don't cause as many side effects. And we can also use radiation to cure cancer and to control cancer. And it's just, to me, very amazing what we can do with radiation. And so that's why I'm a radiation oncologist.
Wow, that's inspirational. Fantastic. That'll keep you going every day. Dr. Lee?
Yeah, thank you so much, Dr. Fields. My name is Percy Lee. I'm a thoracic radiation oncologist at MD Anderson. And also, I'm also on call, so I agree with Dr. Owen that it can be really rewarding to be able to help someone in an acute setting. At the same time, I think I got into the field. I was in the laboratory in Boston at medical school, and a couple of mentors suggested that because I was interested in oncology, look into radiation oncology. And having an engineering background, it really kind of fit what I was looking for, something that's technologically advanced, but at the same time, very patient-centered. And specific for thoracic and other disease sites, we're kind of in the front as far as curative treatments, along with palliative treatment, and now sort of this idea that we can treat cancer not for palliation or not necessarily for cure, but extending life in this oligometastatic era with immunotherapy and other things. So it's really exciting to be able to be an oncologist, but with our tools using radiation to help people. And more things are up and coming as far as what we can do with this modality. So.
Yeah, you're so right. It just gets better. Okay, and Dr. Keene?
So my name is Katie. I work at MGH and primarily treat thoracic patients with thoracic cancers. I agree with everything Dawn and Percy said in terms of, you know, what draws you to the field. I think personally for me, I knew I was interested in oncology, and I really liked sort of the technical aspects of radiation oncology and feeling like a tangible benefit. You know, as Dawn mentioned, you know, it's really great when you treat someone who's having a symptom and you see the symptom resolve. And I would also say that specifically in thoracic, you know, and really all of cancer, but we've seen so many advancements, not just with systemic therapy, but as Percy mentioned, in terms of radiation and optimizing who gets radiation, that we're really able to, you know, improve people's, not only their quantity of life, but also their quality of life. And so I'd say it's just a really gratifying time to be in this field.
Fantastic. Thank you. You guys are all making a big difference. Just a reminder for this afternoon, we're going to go through some cases led by JP. If you have questions, please type them in the chat, and please make sure that you're set on everybody to include hosts and panelists, or maybe just everyone is the best setting, so that we can see your questions and make sure to get them addressed as we go along. Okay, enjoy our session. Thank you, JP.
Yeah, of
Want to
course.
introduce yourself?
Sure, happy to. So, hey everyone, I'm JP. I'm a PGY5 resident here at Stanford. And I guess, I mean, I'll mention why I went into rad-onc, because why not? Originally, I was a physics major in undergrad, and so I came for the physics, but stayed for the awesomeness, because it really is a great field. Like, there's a lot of really cool people that you interact with. You're kind of like at the segue between the surgeons, the medical oncologists, and it's just great at tumor board being able to like throw your input in there and seeing how it affects the management of a patient. And yeah, from a wide array of treatments using a whole bunch of really cool tools that we have at our disposals, we're able to palliate people, cure people, and just make people feel a lot better. So even though everyone thinks that oncology is a depressing field, it truly isn't, because if you look on the bright side, you do impact people in a lot of ways that we couldn't have even 20 years ago. Okay, so case number one. Small cell lung cancer. So you already have the answer. 57-year-old man with hypertension, 3 weeks of non-productive cough, worse when lying on his left side, and improved when sitting up, has some scant hemoptysis for 2 days, and review systems generally negative. So we'll go ahead and ask the panel, what other parts of history are important for lung cancer patients?
So,
I can, oh, go ahead.
oh, sorry.
No, go
So
ahead.
I think, yeah, I think I'm getting back to, like the basics of doing good history and physical. And I think with patients with lung cancer specifically, we really want to assess how they do day to day, like what activities can they do around the house. Obviously you want to ask details of his history with the cough and the hemoptysis, but also get an idea, are they someone who has a lot of health issues and spends most of the day resting? Or are they someone who's up and about, exercising and working? Because all of those are really important things when we consider, what the workup and potential treatment would be.
Yeah, I saw that Hussam put in a very nice mnemonic for looking for different symptoms. So thank you very much for putting that in there. I think it is important to assess what the functional status of that patient is. And I see that, somebody's also put in history of smoking, family history, exposure to arsenic. But asbestos and radon are also risk factors, but you also want to know, are they having any other symptoms? Do they have unexplained weight loss? Do they have any neurologic symptoms? Small cell lung cancer can often spread to the brain and can be very locally advanced when diagnosed. I think having any pain. So you want to do a very good detailed history and physical when you see the patient to kind of take the big picture, but also what's going on right now.
Okay, yeah, exactly. So as some people, including the attendees mentioned, former 40-pack year smoker, quit 7 years ago, 6-month history of 20-pound weight loss, unsure if it's from a new diet or a new exercise regimen. Exposed to Agent Orange in Vietnam as he was a veteran, and no family history of cancers. Overall, his ECOG status is 0, which means sort of at baseline, not affected by his disease, and physical exam otherwise unremarkable. So we'll go ahead and start with the first poll. Which of the following lung cancers is most associated with paraneoplastic syndromes? Great. So most folks thought it was small cell, which makes sense as this is the current case. But if you thought squamous cell, and perhaps we can touch on this through the panel. What are some malignant paraneoplastic syndromes? How do they come up, and which one is most associated with them?
Sure, I can start with that. So they're relatively rare, but more common, I think, in small cell. The thought is that they're triggered by certain types of tumor and an abnormal kind of immune response against the tumor, or maybe when the tumor-directed antibodies overreact with your normal cells. So things that can happen are hypercalcemia, high calcium level, hyponatremia, low sodium, and some neurological symptoms like Lambert-Eaton syndrome, which or myasthenia gravis. So they're just kind of rare zebras that we look for when patients present with them, and it helps us differentiate maybe before we get a biopsy what this might likely to be.
Great, thank you, Dr. Lee. Yeah, so this patient did have hyponatremia secondary to this, which we saw on the chest X-ray, notable left-sided thoracic mass. And so after that, we ended up getting a PET CT to further delineate. And let's see, perhaps Dr. Owen, what do you see on this slice?
So I see a very bright, so we call that FDG avid or hypermetabolic mass that's in the left lung. I don't know if there's a little lymph node in the high lung, but so that is triggers us to say, you know, that's probably cancer, because usually cancer can light up very brightly on a PET scan. And so it would be important for us to, in addition to the PET scan, I know that we will often do bronchoscopy, where we do an ultrasound to potentially biopsy some of the lymph nodes, because it helps us also with treatment to see what the extent is, because sometimes some things don't light up completely on the PET scan.
Great. So we'll continue the clinical course. The PET CT did reveal left hilar mass and lymphadenopathy, as was noted. And you know, Dr. Owen actually already alluded to this, but what are some methods that we can use in general for biopsying either lung cancers or mediastinal things? Perhaps Dr. Keen.
So as Dr. Owen said, you know, a bronchoscopy to this hilar mass would likely be, you know, a way to get tissue from that mass, but it's also very important to biopsy the lymph nodes. I think another important note is that it's good that this patient had a PET CT first, because ideally you want to minimize how many procedures someone has to go through. So obviously if the PET CT had shown something in the liver, then you would go and biopsy that as opposed to focusing on the lung. But for this patient, you know, they could have a bronchoscopy to biopsy the mass, and they could also have either a bronchoscopic nodal evaluation, which is done through the airways and an ultrasound. The other option for evaluating lymph nodes, or the other sort of second most common, is a mediastinoscopy, where a small incision is made and you can biopsy lymph nodes along the trachea or in the subcarinal space. If a node is not avid on a PET scan, so it's not bright on a PET scan, then typically mediastinoscopy would be preferred to make sure you're getting an accurate assessment of what's going on with the lymph nodes.
Great, yeah. So the path revealed a neuroendocrine carcinoma consistent with small cell carcinoma, which is a subtype of neuroendocrine, and then also a level 7, which is subcarinal lymph node involvement. So here's like probably the ultimate question, I guess, in the minds of someone who's just learning about lung cancers. Perhaps Dr. Lee, I could throw this one your way, but what are some major differences between small cell and non-small cell, and why is this classification so binary?
Yeah, I think it's historical as far as differentiating kind of lung cancers. Typically, it's broadly defined as either non-small cell or small cell, and small cell have features under the microscope. There's smaller cells, or they stain for certain neuroendocrine markers like chromogranin and apophysin. And then the rest of the non-small cell typically consists of adenocarcinoma, squamous cell carcinoma as the dominant types of non-small cell lung cancer. And we're learning as we go that they're genetically very different, and now there's subclasses of them molecularly in the non-small cell class. But biologically, we think of small cell as somewhat different from non-small cell. They tend to be more aggressive, more likely to be stage 4 at presentation, and they're more likely to respond to therapy, to chemotherapy or immunotherapy or radiation therapy. But unfortunately, they tend to also come back quickly. So that's sort of one aspect of small cell that's a little different from non-small cell. And they also, I mean, non-small cell can spread to the brain, but small cell has a slightly higher propensity to do that. So that's another important aspect that we should keep in mind when we stage the patient and offer treatment for them.
Great, thank you. So, yep, exactly to that point. They did have a brain MRI at time of staging, and it was negative. So they were ultimately staged T3, N2, M0, limited stage small cell. And so the question is, well, this is a funny way to stage things. What's this LS? We don't normally see that. So Dr. Owen, do you mind briefly touching on what is limited versus extensive stage for this sort of cancer, and perhaps why I have this random picture of a port field here?
So historically, and even now, it's kind of gestalt. Basically, what we defined as a limited stage versus extensive stage was, can we treat all of the cancer that we see in one quote unquote radiation portal? So this dates back to, I would say, even before my time, when we just used to take an X-ray, when we would draw a box and we'd say, this is where the radiation is going. And we're trying to get away from the limited stage, extensive stage staging, which I can see that Dr. Obaid has put on the T and M staging, which is how we typically stage cancer, with the tumor size, where the lymph nodes are, and whether it's spread outside of the lung. And I think there's differences in treatment. So we think we can give radiation up front, and we can encompass all of this in a radiation field safely. Then we would start with chemotherapy and radiation with a curative intent. If we don't think so, then the patient actually would start with chemotherapy, and we would reassess that later for whether we can start the radiation maybe after the first cycle of chemotherapy or after a couple of cycles. So it's a historical context, and we're trying to shy away from that now, because I think in order to compare how people do, we really do need to have the actual stage of the size of the tumor and where it's spread.
Yeah, great. Thank you very much. It was very thorough. All right, poll time. What is your next step in management? Okay, so most participants thought that we should include some form of radiation, since this is a RAD-onc talk. So mostly went with A because they also perhaps thought we should give more than 30 gray. Do the panelists agree?
Yeah, so I think, the standard for a person who has what looks to be a limited stage small cell lung cancer would be concurrent chemotherapy with radiation. Typically, patients with small cell lung cancer are getting 4 cycles of radiation, or 4 cycles of chemotherapy, and so the chemotherapy will continue after the radiation has finished. The second option B is a regimen that you could consider for someone with extensive stage or disease that is not possible to encompass within a field. The third option C, so one other thing with small cells, it's typically not a cancer that we think about responding well to surgery, with the very rare exception of like a stage 1 small cell, which are quite uncommon. The reason for that is so often these patients develop distant metastases, so the relative value of surgery is less. The last option of chemotherapy with immunotherapy would be the standard of care for someone with extensive stage disease. So they would receive 2 chemotherapy agents with concurrent immunotherapy if they had extensive stage disease, and that's the current, NCCN standard for patients with metastatic disease. But for our patient, it would be A.
Great. Yep. Thank you. So let's see. Okay, I guess we kind of touched on this, but what if this patient were, let's say, over the age of 80, ECOG2, not doing so well from this cancer? Would you still want to treat aggressively with radiation, or how would you kind of sway your thoughts?
So I sort of think about small cell as patients really need to get chemotherapy. And so typically for these, and Dawn and Percy, correct me, it'd be good to talk because I feel like this is a challenging situation. Usually I'd say they get their cycle 1 of chemotherapy, and you see them on their 1-week visit when they come back to see the medical oncologist, and you see how they've done. And some people surprise you and have tolerated chemotherapy well. Other people have really struggled. And for those patients, I think it's tough to think about adding in radiation if they've also struggled with chemotherapy thus far, because we really know that these patients need to get through chemotherapy. And if they don't get through chemotherapy, then that's unfortunately a poor prognostic sign.
Yeah, I agree with you, Katie. I think that in some ways, starting with a cycle of chemo or 2 cycles gives you a chance to assess the patient's tolerance. And we know there's data that if we integrate radiation early on after a 2nd cycle, it doesn't appear that the patient would have a detrimental outcome as far as disease control or survival. So oftentimes, but sometimes patients can only get chemotherapy and eventually the tumor will shrink, and sequential radiation is the next best option rather than sort of concurrent radiation. I think potentially another option is just radiation alone, but I would not advise it in small cell lung cancer, given that, as we talked about, propensity of distance spread is high, microscopic disease is likely to be in existence. So systemic therapy, as Dr. Keen said, is quite important to have.
I fully agree with what both Doctors Lee and Keen said. I think testing the waters with some chemotherapy, because small cell lung cancer becomes stage 4 very quickly, is the way to go, and to see whether the patient functionally would benefit from radiation later, or you can always intervene with palliative radiation if things aren't going well as well.
Yeah, great. Thank you for touching on that. So here we have some images of like a dose distribution in color wash of the radiation treatment plan. They ended up getting treated per the Teresi regimen of 45 gray and 30 fractions BID, planned with a 4D CT, and we'll touch on what this kind of means a little bit down the road. But for the medical students, I guess just know that this rainbow looking color wash is representative of the dose that's overlaying the patient's CT, and you can see the red, meaning hotter, is going to where the tumor is. All right, so you may not know this, and that's perfectly fine, but what are some expected acute, or which of the following is an expected acute toxicity most likely to impact this patient's daily functioning in this particular treatment scenario? Okay, great. So most thought it was acute esophagitis. Some thought it was a pneumonitis. Perhaps Dr. Lee, can you briefly touch on what the timeline difference is between these two?
Yeah, sure. From the earlier studies, as we are going to speak about, the common regimen is twice-a-day radiation. One of the things that they found in treating that, because the fields were larger and patients had a lot of their esophagus in the radiation field, acute esophagitis is common starting, I would say, week 2 of this 3-week regimen, as early as beginning of week 2, and can linger till at least a couple of weeks after radiation is done. Typically, pneumonitis is also a risk, but we don't think of it as a common risk during radiation. It's often a few weeks after radiation is done, up to 6 months to 9 months or a year after completion of chemo radiation therapy. But I think in particular, well, one thing I wanted to mention is that with modern technology, I think we've seen that the rates of acute esophagitis potentially are a lot lower than what the historical numbers are. And that's because of, again, our ability to know where the disease is better, limiting our fields, better conformal radiation techniques have allowed us to move that front forward in terms of reducing toxicity for our patients and improving quality of life.
Great. So to continue the clinical course, they did end up getting esophagitis, unfortunately, and this required mechanical soft diet for 2 weeks and also resulted in a 10-pound weight loss, which they bounced back from. So I guess very briefly, what are some management strategies you would give to patients with esophagitis on active radiation treatment to help them get through it? And this comes up in more than just like lung cancer treatments. You could see this in obviously GI cancers if you're treating nearby. So it's kind of a relevant point. Dr. Owen, perhaps.
Yeah, so So I treat both esophageal cancer and also lung cancer. It's pretty common. One of the mechanisms of this pain with swallowing is sometimes an overgrowth of fungus. And so I will start an statin, which is an antifungal rinse. I'll also prescribe viscous lidocaine or magic mouthwash. So that's something that can numb their throat. And they take it 15 minutes before they eat. As things get more uncomfortable, sometimes we'll need to start some pain medications. I also make sure the patient is on really good heartburn medication, because my analogy is always like, if you have a paper cut and you put a drop of lemon juice on that, that really hurts. And if I burn, and I tell the patient, if I burn your swallowing tube and you have a little bit of acid reflux, that really, really hurts. And so I want to make sure that they're on really good PPIs or Pepsid or something to really help with the minimize heartburn, because that can also make esophagitis worse. It's very, very, very rare for patients to have grade 3 esophagitis where you're in the hospital or you need a temporary feeding tube. It's extremely rare if you kind of get ahead of it. And so I counsel my patients, if it doesn't start off as hurting, what it is they often describe as, feel like I'm swallowing a grapefruit, or I have a lump in my throat. It's uncomfortable. And they're like, it's okay. I can kind of tolerate it now. And so that's kind of the tip of the iceberg when things might start to get a little bit more uncomfortable. And so I kind of have that regimen where I tell them yucky tasting mouthwashes, and then we can proceed to something that's a little bit stronger in terms of pain medications. And typically, if my patients are fairly compliant with doing just the rinses, I find that they often don't need narcotic pain medications, and they can kind of get through it. Another thing is they're at risk of dehydration in addition to weight loss. And so we talk about IV fluids sometimes if things are quite bad. And then also if they're having trouble with even just a mechanical soft diet, we really discuss things about not preventing weight loss. And this applies to both small cell and non-small cell lung cancer, because rapid weight loss is a poor prognostic factor. They get weaker, they can't tolerate further treatment. And so we hand out Boost and Ensure. But by the way, both of those also taste awful. And so we talk about different types of ways to mitigate the taste, like making milkshakes, or also recipes for high calorie shakes to try to get those calories down.
Yeah, that was extremely thorough. Thank you very much, Dr. Owen. Actually really helpful for head and neck too, to keep in mind. So some case variations, let's see, maybe we can pick one of these. What's PCI, Dr. Keen?
So, as Dr. Lee mentioned, these patients have a very high risk of brain metastases. And so PCI is prophylactic cranial irradiation. So it's radiation to the entire brain that is typically considered after patients have completed chemoradiation. Now, obviously, it's a careful discussion that you have to have, because radiating someone's entire brain can cause significant side effects. And many patients have commented to me, and Dawn and Percy, please chime in. Like I've had multiple people tell me that PCI is the toughest part of the whole treatment. And so I think it's not something to consider lightly. MRI surveillance is another thing to consider. In the years when the PCI data emerged, that was before MRIs were done routinely. And now we have these excellent MRIs with very thin slices. And so the thought is that, could you replace PCI with MRIs? For patients with extensive stage disease, we have data to support MRI surveillance rather than PCI. For those with limited stage, I think it's still a discussion. If I'm treating a young patient who's tolerated chemotherapy and radiation well, then I certainly do talk to them about it, but it has to be a very careful consideration of the pros and the cons.
I just want to poll you guys. It sounds like, Katie, you're a little bit anti-PCI, because I find it's very polarizing within the radiation community. Percy, what's your thought?
Yeah, so my personal thought, and we have a large group of thoracic rat lung, so it's also variable in our group. I'm on the side of PCI is still standard of care for a patient population that's limited stage. So there's some caveats. I think if they're much older, we tend to be worried about their cognitive effects more than if they're younger, or they've had pre-existing conditions that lend themselves to having more effects, early dementia, et cetera, or poor performance status. If they're really young, I think it's really important to discuss the potential benefits and harms so that they can make an informed decision. So I don't I don't strongly say like they should do it, but I give them the reasons why they should consider it. And it's similar with extensive stage. I'm actually not a big fan of that based on the controversial data that we do or don't have to talk about, but there's just mixed data in that space, depending on whether they were imaged prior to PCI or not. Last thing I want to say, there is ongoing trial that's in the cooperative group studying this question called Maverick. It's for both extensive stage and limited stage. So they're randomizing patients to either or with different options of PCI to fully kind of vet this question. As there's been retrospective studies out of Anderson and other places that suggest surveillance MRI may be enough for these patients rather than PCI.
I think another question is, if you're going to do PCI, could you do something like hippocampal avoiding PCI, or something to mitigate as best you can some of the effects? And that is something I've done, obviously off protocol in some patients, again, it's a complicated space.
Yeah, if I do PCI, I always do hippocampal sparing, and I start my mantine. So I do everything the NRG CC03 did. And I do predominantly treat young, I do discuss it in younger patients. Maybe I'm in between. I'm like, I'll have the discussion, but I don't strongly recommend it, even though ASTRO, their small cell guidelines that came out, do suggest and say that it is still standard of care based on the meta-analysis that showed a survival benefit. And there is cohort data to suggest that once small cell lung cancer patients get brain mets, they don't do well, that the survival is limited. So that argues to some degree in favor of considering PCI in patients who are young and fit. And there's a question about, do all stages of small cell require PCR MRI surveillance? And so I think we kind of talked a little bit about that, but I think it's a nuanced discussion with the patient, as we said, and even if you do PCI, you still need to do MRI surveillance because it doesn't reduce the risk of brain mets down to 0.
Yeah, I think the only thing I would add, that's perfect. The only thing I would add is that there's a concept of hippocampal sparing PCI. That's the idea that we could treat the whole brain and spare the hippocampus, which is thought to be the main detriment of irradiating the brain as far as cognitive effects. And that's been validated in metastatic non-small cell lung cancer in a couple of large trials, but in the limited stage PCI world, there's an ongoing NRG trial, but there's smaller kind of European trial and also a South American trial. The one trial was negative for preservation of cognitive effects. I think a recent trial in Europe was positive. So we're waiting for sort of the larger validation trial. So in that sense, if that could be a good intermediate option, if it's truly proven to be able to, improve outcomes clinically, but also preserve cognitive function.
Great. Thank you, everyone. That was really thorough. So we'll go over to case number 2. If I can turn my pager down. Okay. And this is early stage non-small cell lung cancer. So it's a 62-year-old woman. She has a 100 pack year current smoking history, presents with a lung nodule seen on screening low-dose CT. So, well, we'll go ahead and ask what is that? What role does low-dose CT screening play in your practice, and of what benefit? Has it been as widely adopted as you or others maybe think it should be? Dr. Keen.
So low-dose CT screening has been shown in some large randomized trials to improve the likelihood of cure from lung cancer when you compare to doing things like X-ray alone. And so in the US, it's recommended that patients who have more than a certain duration of smoking history and are over a certain age, typically over 55, at least 20 pack years, are candidates for a low-dose CT done once a year to screen for pulmonary nodules and ideally find lung cancers early. Now, the uptake of that has been somewhat mixed, and I've seen numbers as low as like less than 10% of patients who would qualify for it having screening. So I think it's definitely an area where there's a lot of room for improvement. And I think it's something where we're often trying, talking to the primary care doctors, in our groups about the benefits of it, because it is, certainly an important thing to consider. Because ideally you find these lung cancers when they're a stage 1 or even a stage 2, but before they've had a chance to spread and cause symptoms.
Excellent. Yeah, thank you. So here I threw on some kind of like representative, but not totally accurate images of like what the difference might be. So I think this is a little exaggerated, especially today because these have improved. But in general, for the medical students, it's like, here's the difference in quality between a diagnostic and a low dose screening image. And so usually, you know, a mass is a mass, but the ambiguity lies around seeing more like finely resolved speculations and things like that, which could be suggestive of certain features. But again, I think this image is a little exaggerated, and today's low dose CTs are pretty darn good. All right, so a non-contrast chest CT was obtained, and it's a dedicated diagnostic chest CT. And well, let's talk about this lesion. So Dr. Owen, what do you see and what makes it potentially look concerning to you?
So I see a white blob, which I would call a mass in the left lung. It has spiculation, so you can see little fingers outside of it, so it's not nice and smooth and round. It looks very abnormal because of the shape of it and the location. And so I think the speculations and certainly makes things look suspicious. Being solid makes it very suspicious on a CT. And certainly if patients have had a previous CT, seeing serial growth is also one sign. And we also see things that are what we call ground glass. I don't know what ground glass really looks like, but the radiologists call these gray kind of cloudy things in the lung. If they become more solid over time, also is suspicious for cancer development.
Yep, 100%. And then this probably also adds to your suspicion because you order a PET CT and it comes back super avid. So moving on, additional workup. PET CT, besides what we just saw, was negative for distant disease. They did have an MRI brain again, and this was negative. And then they ultimately got a CT guided biopsy, which revealed adenocarcinoma, EGFR, and ALK wild type. So we now are at this point. We have a T2, N0, M0, and I probably should have told you how we got to this, but it was through size, adenocarcinoma of the left upper lobe. So it's time for a poll. What definitive treatment options does she generally have? Okay, so most people thought all of the above were good treatment options. Does the panel agree?
Well, we didn't talk about workup for the lung cancer, either small cell or non-small cell required pulmonary function test, but that would definitely be something we should get in everyone in addition to all the scans. And really, I think the standard of care would be a left upper lobectomy in a patient who's a surgical candidate. Now, we're not surgeons, but I would say our surgeons, everyone's surgeons looks at how fit the patient is. We look at the pulmonary function test. So you want to make sure their FEV1 is over 1.5 liters. They want to have a good DLCO that's, you know, really over 40%, really over 50%. So comorbidities also factor into whether a patient is operable. For example, the patient had a recent CABG or has a significant heart disease or needs a TAVR, or the patient isn't very functional, or they had trouble, you know, even with the biopsy, or they had a bronchoscopy and they barely woke up from the anesthesia. Those are all kind of red flags that they may not be as well served by surgery. And so then technically, as I said, if they are surgical candidates, surgery is the standard of care. But SABR is an excellent option for patients who refuse surgery or who are also, or who are not operative candidates. And it was, that's stereotactic ablative body radiation. I still call it the old school name, SBRT, with stereotactic body radiation. It's the same thing. Basically, SABR just is a cooler name invented by one of our radiation oncologists. And of course, there's a Stanford bias towards the name SABR. And so it was invented by Stanford. And so basically we would, so what that means is treating in 3 to 5 treatments, very, very high dose treatment. Now, Dr. Lee is a world expert on hypofractionation. I don't know if I would offer hypofractionation here. I think that tumor is safely treatable with SABR, but I'd be interested to know what he thinks and what Dr. Keene thinks about the role of hypofractionation in this case.
Well, that's too kind. I didn't know I was a world expert on hypofractionation, but I have treated with a lot of patients with that. I think, I agree with you fully. I think I would, if the patient is medically inoperable, my number one option would be a SABR SBRT with a high dose. There's a concept that dose beyond 100 gray biological effective dose appears to be more effective in terms of controlling the cancer, but potentially survival outcomes. And I would reserve hypofractionated RT for a patient like a tumor that's closer to the mediastinum, what we call centrally located tumor, 10 fractions or 15 fraction is something we would commonly do. And then the concept of the operability, I think Dr. Owen already well described. I think that's an also evolving area where some operable patients may be better served or potentially served by SBRT down the line. There's a couple ongoing large trials trying to answer that question. It'll be a really exciting era for us if kind of SBRT becomes not necessarily the only option, but considered as a reasonably equal option to surgery for some of the operable patients.
And I would agree that I'd prefer, if they can't have surgery, SBRT. I think the other important thing is that this is a patient who definitely, no matter what they have, unless there's an absolute contraindication, needs some sort of invasive nodal evaluation, because given the size of this tumor, even if the PET is negative, there's still a high risk that there could be lymph nodes involved. And obviously the stage and everything will totally change in that case.
Yeah, that's a very good point. Thank you. So they end up getting a simulation scan whereby you acquire a 4D CT and a 3D breath holds, as well as a PET scan. And so you end up getting this sort of fusion, which we see. And let me see. This next slide, I think, has like a video, but yeah, it should be kind of playing. But Dr. Keene, I may ask you to just briefly explain what a 4D CT is, because it sounds like some science fiction.
Yeah, so I think there are a lot of different ways of doing CT scans. Most of the diagnostic CTs that you see, like lung cancer screening, a patient's holding their breath. Certainly it's challenging for someone to hold their breath beyond 15, 20, maybe 30 seconds at most. And a lot of patients with lung cancer definitely can't. But we also know that everything in the chest is moving. So 4D CT is incorporating basically multiple CT scans throughout the phases of the breathing cycle. So a patient has typically 10 scans taken at multiple positions. And then that gives you an idea as to how things are moving when people are breathing. Because typically with lung cancer radiation, we're treating patients just breathing normally as all of us are right now, rather than having them hold their breath or things like that. If a tumor is moving a lot, then it's important to account for that in the planning and either try to minimize the movement or use techniques like respiratory gating, where you only have the radiation beam turn on during certain parts of their breathing cycle.
Great, thank you very much. And here are some superimposed contours to target the cancer that we want to treat. And let me see if this plays as well. Okay, maybe not, but anyway, so these are superimposed. And Dr. Owen, can you touch on the concept of an internal target volume? Because that's not something that we often see when we think of the 3-step paradigm of GTV, CTV, PTV.
Yeah, so this is basically a volume that encompasses the motion of the tumor, and it's considered, well, it's considered part of, I guess, your CTV. So historically, we used to just treat lung cancers with just the gross tumor volume, and then we expanded it to a clinical target volume, which is the microscopic disease. But what we've learned is that we can miss the tumor because it's moving, and as the patient is free breathing, we want to make sure we capture every single position that that tumor can be in. And so that's what the internal target volume is meant to do.
Great, thank you. All right, so here's the radiation treatment plan with a superimposed dose distribution. So last time I showed you this in a color wash, but similarly, it could be shown using this technique, which are called isodose lines. And they represent the same information, just displayed differently. But yeah, here is, well, I guess maybe I can have Dr. Lee speak as to what you see on this kind of eclipse setting. Like, what's this beam?
Right. So there's various ways to plan the radiation, and as Dr. Owen already described, what's important, number one, is figuring out what's your motion management strategy. Depending on how much it does move, there's a number of strategies. We don't have to get into details. In fact, those are the fun things, I think, the technical fun things of thoracic radiation. In this case, it looks like these are the color lines, or what we call isodose lines, to describe volumetrically, you can see in 3 planes, what that volume is getting relative to the dose you're prescribing. So 100%, for example, I'm not sure, this could be 54 grades. So 100% is the yellow that's surrounding what we call the PTV. So it's covering that well. And then what do you notice a little unique about SBRT compared to other types of treatments, that we actually we want the tumor to get much higher than what we prescribe. In this case, it's 20%, but in some other cases, and this could be the case too, just not display, it could be as high as 40%. So we're talking about 90 gray to the tumor. And we think that it has 2 advantages, which is physically allows the radiation dose to actually, contrary to what you might think, drop off quicker. So it spares normal tissue better. And then 2, we think the actual doses to the tumor at that high contributes why the control rates are in the 95 to 97% range for the tumor control. So, and there's some caveats when we don't want to do that, and we can get into further about the technical aspects, but there are some nuances to that as well.
Awesome. Thanks a lot for that review. So here are some case extensions. So I think the first one's a good point to help kind of solidify when we use each of these different SIM techniques. So what if the tumor moves a lot, say greater than 1 cm? Would we try to do like a huge ITV? Dr. Keen?
So there are different ways of managing people's breathing and motion. You know, one way, the center panel, is abdominal compression. There's also active breathing control. I think what I will say is sometimes it's variable how effective or not those can be. I think it's good to use whatever you can to minimize motion, but sometimes we are left with still needing to use things like respiratory gating, which was typically when the beam only turns on and delivers when patients are exhaling, which tends to be the most stable part of the breathing cycle. I found that some patients with abdominal compression, their breathing pattern, the extent of respiratory motion doesn't decrease, it just becomes odd. So sometimes people, I feel like, try to breathe around it. And also sometimes frailer patients can be pretty uncomfortable with the compression. So I think certainly there are multiple ways to manage it. And whatever it is, you want to make sure that it's something that a patient can tolerate comfortably for 20 to 25, sometimes even 30 minutes.
Yeah, there are definitely technical limitations. For example, if a patient's quite obese and you try to use an abdominal compression plate, it's very hard to keep them in the same position every day because you're really just kind of squishing adipose tissue and you're not really making it uncomfortable for them to breathe deeply. And as Dr. Keen said, it can make their breathing erratic. There are different ways to hold their breath. So the one that's shown is ABC or SDX, where they basically have a nose clip and there's feedback, and it kind of forces them to hold their breath. But there are also voluntary breath hold techniques where the patient looks at a little panel or has goggles and they can see themselves breathe. And at the time of the simulation, when we do the scan to plan the radiation, we set what's called the gate. So we're trying to get them to hold their breath in the same position each time. And sometimes that's a little bit easier because the nose clips can be and the mouthpiece can be difficult to tolerate for some patients. And gating, meaning turning the radiation beam on at a certain time in the respiratory cycle, is really contingent on the patient having a fairly regular breathing cycle. So I've had patients who are really slow breathers, and you're like, oh my gosh, did they fall asleep? The breathing cycle is completely different from when I scanned them, and we couldn't gate them. So there are some technical nuances, but certainly we do want to try to limit the motion of the tumor using these techniques.
Yeah, the only thing I would add is that all these techniques have caveats, as Dr. Owen and Dr. Keene has said. One of the main ones I think of is that during treatment, most of the machines you actually are not visualizing the tumor. So you kind of guess using surrogates. Sometimes it's infrared markers on their abdomen, or sometimes, yeah, that's mostly the case. You don't always know what's happening, so because patients can breathe in a different pattern at the time of treatment that day. So that's the caveat of gating versus treating the whole motion envelope. That caveat is that you might be treating a large volume of disease or normal tissue.
Well, for gating, I know what we do here is we actually do an X-ray during the gate to make sure that we can see the tumor. So the gating is also to some degree limited by whether you can see the tumor well, or you have a surrogate of that tumor motion. So, I mean, this part of the fun thing about radiation oncology is we can nerd out about how we can limit the motion of a lung tumor, and we all have different ideas of what's best. It's part of the fun of the technical aspect of radiation oncology.
Right, and I refrain talking about MR Linux, but that's my other passion.
Yeah, thank you guys very much for that. So if the med students didn't take away like all the tools and tinkering in the garage is great, but it just answers this one question. But what you should not do is have like an ITV that spans like 10 centimeters. That's not good. And then I guess the last thing we can touch on, any recent data supporting not treating overextended fractionated courses, but using SABR for these type of early stage non-small cells?
Yeah, so there have been a couple of studies. One was called SPACE trial, which was done comparing standard fractionated radiation. This traditional is 60 gray over 30 treatments, 30 sessions, versus SBRT or hypofractionated approach. It was a smaller study, so unfortunately it didn't actually show that SBRT led to a better outcome, but some of the nuances were that patients were stratified in a way that bigger tumors were in the SBRT arm, and more men, for example, was in the SBRT arm. They tend to do worse in general for cancer, but specific for lung cancer. Luckily, it was followed by another study, about 100 patients, called CHISEL. It's from Australia, randomized against SBRT essentially versus a standard fractionated approach. The primary endpoint was local control, and it did show SBRT was improving that aspect, but also survival as a secondary endpoint was also improved in the hypofractionated or SBRT cohort. So in many ways, we think of that study has established the standard of care as SBRT for these early stage medically inoperable patients.
Great, thank you. So that's what I had for the early stage one, and I think I'll run it by Jenna, but since we're approaching the end of time, we could probably skip over to the conclusion.
Sure.
Okay. We got through 2 cases. Great.
So thank you to our panelists. Thank you to our moderator. Thank you all for joining. And thank you to our ROVER coordinator, Nav. Please be sure to fill out the post survey. We always send out those Amazon gift cards. Next slide. You can always contact us, and the website is updated for the next sessions. Next. You can also find different opportunities on the website. You can contact faculty from all different institutions, and there's meet and greets are also on the website. Next slide. The next session will be in 2 weeks. Actually, the session before that, we'll talk about that in a second, but on September 17th, the GU malignancy. And the next slide, we will be doing on September 16th at 4 p.m. Pacific time, 7 p.m. Eastern time, a networking session. And then after the networking session, there will be interns who applied last year to do an open Q&A. So sign up for that. I think the sign up might be already closed, but please reach out to us and we can put you on the registration for that. And with that, thank you to everyone.
Thank you.
Yeah,
This was
thank you.
fun.
That was a great
you.
session. Thanks so much.